Tonight's presenter is Dr. Peter Koehn, who is a professor of political science right here at the UM. He was a distinguished scholar for 2005, a Fulbright New Century scholar, a recipient of APLU's 2011 Michael P. Malone Award for International Leadership, and the 2012 George M. Dennison Presidential Faculty Award for Distinguished Accomplishment, and the director of the Global Public Health Program. Over the course of his career, he has taught and conducted research in Ethiopia, Nigeria, Eritrea, Namibia, China, Hong Kong, and Finland. For his New Century Scholar project, Peter researched migrant healthcare in Finland. He has published articles about migrant health and medical education in Medical Anthropology, Academic Medicine, Journal of Immigrant and Minority Health, Globalization in Health, Global Social Policy, Journal of Transcultural Nursing, and Journal of Refugee Studies. And today he's going to talk to us about transmigration health challenges.
Well, as you can see from that introduction, I believe that I'm really quite an imposter in this lecture series, because I'm the only one who really hasn't done anything in terms of actual health contributions in the Global South. I've done some research, and I think this presentation is going to be more of a scholarly presentation, but the closest I can come to having done any meaningful contributions to health overseas was when I was on a mission with UNICEF in Eritrea. And I was working on decentralization of local government for social and health care needs. So not actually doing the health care, but trying to help the government organize itself so that they can provide effective health care services. So please recognize right from the start that I'm the imposter in this lecture series. So as backdrop, I'd like to say that we live in an age of population mobility, and about 1 billion people traverse nation-state borders annually, and at least 1 billion people a week move between the global south and the global north. And so that's why this idea of transmigration is very important. People are moving back and forth, not just in one direction, but back and forth. And so today, we recognize that there are 3 key determinants of health, and that is place, access, and competence. I wonder why they're not showing up here. Okay. And I plan to show how these 3 conditions govern vulnerability and opportunity. And throughout the talk tonight, there's a recurring theme, and that recurring theme is the impact of armed conflict on health. So I think if there's one issue that I really want to focus on the most, it's that issue of armed conflict and health. So first of all, place. The place where you reside largely determines both exposure to health risks and the possibilities for health care. It includes such things as the number of doctors and nurses and the number of other providers in the vicinity. Access is second. Access means that if you're going to receive care, you also must be admitted to whatever services are available. So you need to be in the right spot, but you also need to be admitted. And access is largely determined by 2 factors: supply, the availability of these facilities and staff, the ability to pay or one's wealth, and actually a third factor too, which is policy. And the policy to be admitted has to be a non-discriminatory policy. Otherwise, you might be excluded, even though you're in the vicinity where there are providers. And that's the struggle that many people in the Global South face. It's not that there are no providers, it's just that they're not available to them because they're only available to those who are relatively wealthy. So the third condition is competence. And competence involves both medical competence in a technical sense and interpersonal competence. And my primary interest as a political scientist is in the latter. It's in interpersonal competence. So these are three things I'm going to talk about tonight: place, access, and competence. And these three determinants are interconnected. And they're interconnected in multiple and decisive ways. So if you want to look at it in a relatively simple and straightforward progression, our place either enables or constrains access, and access enables or denies the opportunity to interact with people who are competent, or the exposure to competence. And access to competence then largely shapes health outcomes. So you need to have these three things. You need to be in the right place, you need to get admitted, and then you need to be treated by people who are competent. So let's move on to place first. And I have a number of slides that deal with place because your physical location is a major determinant of health. So there are 5 vital contexts for place. And I want to examine each of these in some depth. So the first context is underprovided areas. And most underprovided areas are in rural and remote places. And so one revealing indicator of the number of doctors is the number of doctors per capita. And we find huge disparities between the North and the South in this regard. So the first example I wanted to give with you, and I could bring up other examples as well, is Burundi. In Burundi, there are fewer than 300 doctors to serve a population of 7 million people. And most of those doctors practice in the capital. I took that from Kidder's Strength in What Remains, another book that he wrote that is a really powerful book that he published in 2008. And then secondly, there's this global shortage, which I mentioned in my introductory lecture, where if there's 4.3 million health workers of all types, but this shortage isn't equally distributed. It's especially acute in some areas. And so the next slide shows the places. Yeah, let's go back. So this slide shows the places, and you can't read the instructions here, but I can tell you what it says. It says countries with a critical shortage of all healthcare providers. And you can see from the map that most of those are in Africa, India, and a few other places in South Asia are also there. And so Africans are particularly challenged by the shortage of healthcare providers. While Africans have about 24% of the total global disease burden, they have 3% of the global healthcare workforce. I took that statistic from the New England Journal of Medicine. And this won't surprise you that there's a great disparity when there's a great disparity in the number of available providers, then that leads to a lower life expectancy. And you know, I've talked about this before too. It's very humbling to think about the fact that if you were born in Africa, the accident of your birth would mean that on average you would live 28 years less than you would if you were born here or in Europe. So that's a disadvantage, but there are other places that are disadvantaged too. So you might have been born here. That's not particularly healthy either. Does it look very healthy to you? It's Does anybody want to guess where that is? Yep, you're right. That was Harbin in China in October of last year, when the pollution got so bad that they had to close all the schools and all the roads. So one of the things we know is that poor air quality is responsible for about 500,000 deaths a year in Chinese cities. About 14 of the 16 most polluted cities in the world are in China. So that wouldn't be a very good place to be born either. But there might be an even worse place to be born, and that's here. Anybody know what these pictures are of?
South Sudan.
It's close, but not. This is Guinea, and this is the effects of Ebola. Ebola has an extremely high mortality rate, something in the order of about 90%. And it's a horrible disease to die of. And when you get Ebola, no one wants to even be in touch with you, so they have to wear all these things in order to prevent the transmission of this disease. And there's a story I read about a man who carried his friend who had Ebola from his village to the hospital, and he came down with Ebola too, and they both died. And Ebola is something that is spreading now in several of the neighboring countries to Guinea, and it's got a very long incubation date. You can be incubated for 2 to 21 days, so it's not impossible that it could be spread beyond Africa as well. So, availability. The scarcity of trained health workers in low-income places is exacerbated by out-migration. And what we see is a number of health professionals leaving their countries, moving to rich countries where pay is many times higher. 1/3 or more of Africa's highly educated professionals are estimated to live in industrialized countries. That's all professionals, not just medical professionals. In Malawi in 2012, 64% of the nursing positions and 95% of the physician positions were vacant because there was no one in the country to provide that expertise. And Malawians are notorious for settling in the Chicago area. And these disparities are actually growing. And they're growing in part because there's some new countries that are importing expertise from the global south. And that includes India, China, and the Gulf. So it's not just the US and Europe any longer. Those countries are aggressively recruiting. So altogether we call this the fatal flow of expertise. Now, what that often requires is a situation which we call task shifting. And in task shifting, what happens is nurses sub for doctors, and community health workers sub for nurses. And traditional healers, sometimes they're brought in on the side or to sub for community workers. So there are arguments on both sides of this in terms of whether or not that's a good thing. We talked about some of this in my class today. On the one hand, it does mean that you get less experienced and expert care. But on the other hand, these nurses and community health workers sometimes are even better informed about local conditions and able to really understand what you need even better. But whether it's a good thing or not, it's happening more and more. And so finally, these disparities aren't limited to the global south. We have these kinds of disparities here in Montana. 54 of our 56 counties are areas that have been declared primary care shortages. And in 11 counties, there's not even a single doctor. So next week's lecture by my daughter Narissa is going to talk about the residency program, which we've established recently here at the University of Montana to try to address some of those shortages. And she's going to bring some residents to this class to tell you how international experiences can affect their careers. So one other thing that's beginning to happen, and I like to see evidence of reverse care, reverse innovation. I'm not sure how much of an innovation this is, but certainly it's a case of reverse care. So as our society increasingly ages and we have more and more elderly, we have fewer people among our own citizens who are prepared and willing to take care of the elderly. So what happens often is immigrants are filling these northern care shortages as the number of elderly and disabled increase. And so that's a picture of an immigrant helping an elderly man. Now, at the other end of the transmigration continuum, the provider continuum, we have a development called health tourism. And I wanted to spend a little bit of time on health tourism for you because I think it's, well, I'll let you draw your own conclusions. So let's take a little time to look at this slide. This is an advertisement that I found on the web for health tourism in India. And India is a very popular destination for health tourists, but it's not the only one. And so you can see all the different things that they advertise that they can do. And here's, I think, some interesting comparison in terms of costs. I mean, pick any one of these. Liver transplants, they would cost about $500,000 in the United States. In India, you can get a liver transplant for $40,000. So it's not surprising that more and more people are turning to health tourism to get the care that they want, and usually high quality care as well. And of course, one of the, well, let me just say, it's not all liver transplants. It's also things like plastic surgery, hair replacements, some of these other more frivolous kinds of things that can go on there as well. And as you might expect, one of the consequences of health tourism is the number of providers who stay in the country, remember there's a shortage already, who are actually treating people from that country is reduced because they're spending all their time treating people from this country or Europe or wherever it might be who are coming to India for a hair transplant. Okay, so I mentioned I wanted to talk a little bit about conflict. So I want to talk about conflict zones. And one of the things that we know is that there are a number of refugees and internally displaced persons around the world today. About 30 million people are internally displaced. I haven't seen the latest number of refugees, but it's somewhere between 14 and 16 million refugees. And an African war study carried out by the Physicians for Human Rights group concluded that the first killer is flight for desperately poor people who are driven by conflict from a fragile existence to begin with to a hostile and personally threatening environment. And when they get to that place where they're driven to, they find out that health services are either non-existent or they're not functioning. Or in some cases, they have to escape into the bush, and there's no hope of getting any kind of health care there. So one of the things that has changed since the Second World War is that when we have armed conflict, the brunt of the casualties of armed conflict now falls on civilians and not on the armed forces. So roughly, it's estimated that about 80% of all casualties from armed conflict are civilian casualties. These aren't all deaths, and so one of the consequences of armed conflict is a great increase in the rise of disabilities. And so disabilities is an ongoing health issue that many countries just are unprepared to deal with, but they're finding an increasing burden. So I'm going to show you some slides. Don't worry, the worst slide I showed you was the one about Ebola. The rest of these are all manageable. But this is a slide of what happened thanks to Israeli F-16 bombs dropped on a medical center in Gaza. So you get some sense of what was left and the desperation of those left behind. This one is the charred remains of the Lubo Savor Public Health Clinic in Thailand. Militants torched that the night before this picture was taken, just last October, and the fire completely destroyed the entire bottom floor, which housed consultation rooms, a pharmacy, an emergency room, a delivery room. And after the clinic was burned down, the Ministry of Health officer came and said, we're just incapable of providing the same kind of services that clinic provided. We don't have facilities at all. So about 8,000 people lived in that sub-district, and he said they would have to seek medical help in neighboring sub-districts. Now that can involve some very difficult transportation issues. This one is a local clinic burned to the ground by the Burmese army. And about 2,000 people were forced to flee to the jungle as a result of this clinic and the continued hostilities that went on. So now I want to go to Syria. In Syria, there are about 2 million refugees and about 5 million IDPs, internally displaced persons. And the number keeps rising. And more than half of Syria's hospitals have been destroyed or closed for other reasons. Many of the medical staff have been targeted for attack, both by the regime in terms of its airstrikes and by armed rebel groups. So 15,000 doctors have been forced to flee abroad from Syria. Syria had a pretty good functioning medical system before the civil war broke out. And of the 5,000 physicians in Aleppo before the conflict started, the estimate is there are about 36 still there. So we went from 5,000 physicians to 36. So what are people doing? Well, what people are doing is they're seeking recourse at primitive field hospitals. One of those primitive field hospitals are the living rooms of people who are living in that particular area, run as volunteer operating theaters. A couple of consequences of that, just to mention a few. One is the number of unassisted births has increased dramatically. And a second is that the number of amputations has risen dramatically because these amateurs really can't find any other way to deal with the problem except to amputate. So, Save the Children in March of this year, just a month ago, issued a report. And of course, they're focusing on children. And they said that at least 1.2 million children have left Syria, fled Syria altogether. And about 10,000 or more have died in the violence or because they could not get treatment for disease. And Save the Children interviewed parents, children, and providers. And what they came up with in their report was the picture of healthcare in Syria today is of medieval health conditions. Syria has gone back to medieval health conditions. And UNICEF in that same month issued a report where they said, and I'm quoting, Syria is now one of the most dangerous places on earth to be a child. So you wouldn't want to be born in Syria either. Now, even more recently, we have the civil war in South Sudan. And in late February of this year, Doctors Without Borders reported that patients have been shot to death in their hospital beds in South Sudan. And the MSF's medical facilities have been looted and burned to the ground. So you can imagine when you're dealing with a shortage of facilities and staff to begin with, what kind of impact these kinds of armed conflicts have. So one of the things that happens then when you talk about transmigration is a lot of people move. They go away from the place where all of this violence has occurred and where they can't get any treatment. And so they transition. And they, in the process of transition, when they're on the move, they typically leave everything behind, and especially including their social safety nets. Because many of these countries, most of these countries, don't have any kind of welfare system, any kind of health insurance, anything to provide for them except their family, their extended family and their friends. So when you uproot yourself and you move, you leave all of that behind. And not only that, when they get to a place in transition, they're crammed into a particularly unhealthy spatial surrounding with lots of other people and all kinds of other illnesses and diseases around. They don't have safe water, they don't have decent sanitation, there's no hygienic housing conditions, and often there's not even nutritious food. So they're suffering from a number of different problems. Here's a quote from a report on internally displaced people in Syria. Even in safe areas, the displaced, quote, spill from every corner. They live crowded into shacks, gyms, hallways, apartments, and storefronts. So I wanted to kind of give you a picture of what some of that might look like. This is the UNHCR's Zaatari camp for some 160,000 Syrian refugees as of July of last year. Lebanon has even more refugees. And this is now Jordan's 5th largest city, this refugee. So you can imagine. We're in the middle there?
Well, in the middle and like in the walk, this is like very smoky.
Here?
In the distance?
No, I think that's just water.
Is that just water?
That's
Okay.
water. And this is some numbers here on South Sudanese refugees and internally displaced persons. Internally displaced, almost 800,000, over 125,000 in neighboring countries. And this is a picture of what was going on in a camp for internally displaced in southern Sudan when Korean peacekeepers were providing them with water. And that gives you a kind of a close-up of what the conditions are like. For many people, then, mobility transitions encompass social isolation, psychological distress, marginalization, segregation, and discrimination. So it's not just the unhealthy physical conditions, it's also the mental conditions. And as a consequence, then, transition zones generate risk-taking behaviors that are associated with increased susceptibility to and spread of chronic as well as communicable diseases. So desperate people do desperate things, and that often gets them into even more trouble. So here's another aspect of transmigration, and that is involuntary migration. We're going to have a big lecture series here this week, I think, at the Mansfield Center on human trafficking. And what I wanted to say is at all stages of the migration process, transportation stage, transit stage, and destination stage, irregular migrants are especially vulnerable to contracting disease, to injuries, and they have higher mortality rates. I guess I had a couple of slides here on that. The smuggled and trafficked are the most vulnerable from the pre-departure stage to the travel and destination stage. Women and girls may experience repeated physical, sexual, and psychological abuse, or even torture. That's a quote that comes from the UN Entity for Gender Equality. And one of the consequences of this is that their condition often requires them, I guess I'm skipping a little bit here, sorry, to seek medical attention through unofficial and unsafe means. If you're a a smuggled or trafficked migrant, you're usually in a place where you're not allowed to be. You're illegally there. So the only way you can get health care a lot of times is on essentially the black market. So finally, we have the arrival at a reception place or a holding place. And one of the things that's often overlooked by people in general and by scholars is the fact that when you get to that receiving place, there's often a number of trauma conditions that negatively affect health as well. And several of these are stress from discrimination, the fact that you don't speak the language, high unemployment, or at least underemployment. You're not able to use the skills that you had in your home country because nobody recognizes them. Identity conflicts, who am I? And separation and loneliness. And on top of all this, the conflict that you fled from is still going on in the country that you left. And you may have relatives there as well. And so you're getting disturbing news from home about the situation there. So consequences of the situation. These photos this is the Australian Center for Asylum Seekers on a remote island in Papua New Guinea. This one is a British center for 200 asylum seekers, and they mix those asylum seekers with foreign prisoners in the UK. So now let's talk about access. As I said earlier, location at a staffed and equipped geographical place is hollow if you can't get access to the care that's available there. And there's two major constraints. One is affordability and insurance. So in many cases, poverty is the leading determinant of healthcare access for both infectious and chronic illness. And there's a vicious cycle here. That poverty increases infectious health risks. So if you're poor, you're less likely to have access to clean water, to adequate sanitation, and it increases the risks of cardiovascular disease, diabetes, respiratory diseases, and cancers. One of the things we know in this country is the highest exposure to toxic contaminants is among people of color and the poor. But even taking class into consideration, people of color are more likely to be living close to places of toxic contamination. At the same time, poverty diminishes your opportunity to access preventive care and curative treatments. That's, I guess, probably obvious. And then there's the rest of the vicious cycle, which is if you're sick and you have to pay a lot of money for health care, oftentimes you bankrupt yourself and you fall into poverty. And so there's this great book that I recommend to you by Krishna called One Illness Way, where he talks about how households fall into these poverty traps. And he especially talks about that in the context of India and Uganda. And then we have discrimination. So wherever they're placed, most transmigrants, particularly undocumented, struggle to secure access due to outright discrimination as well. So the final determinant that I wanted to talk about tonight is competence. Health competence is undermined when you find yourself as a transmigrant in a situation where your health provider, your service provider, is not matched with you. So how might unmatching occur? Well, they might not be matched by you by nationality or by ethnicity or by class. And this is all common today because both of the movement of people and because of the movement of physicians, the fatal flow of expertise. So patients in U.S. rural areas today frequently encounter foreign doctors. And in the UK, most nurses are transmigrants as well. So it works both ways. It's not just the migrant who's not matched with a provider, but it's the local population who often aren't matched with the provider as well. And this is all further complicated by the growing use of transnational, even sometimes virtual care. So I wanted to spend a little time talking about that because that's a subject that I've done some research on. So I have this colleague, Marja Tiilikainen, at the University of Helsinki. And her studies, she's an anthropologist, of traditional medical attention among Somali migrants in Europe were very illuminating. She interviewed Somali transmigrants and asked them how they viewed healers in Somaliland along with their treatments and medications. And they said that those treatments in Somaliland were culturally familiar, authentic, and trusted. So Somaliland is not Somalia. Somaliland is a northern part of what used to be Somalia. And Somaliland is actually basically very well run, more or less democratic, somewhat prosperous, and seeking to have its own country be recognized, but nobody's recognized it yet. So it's not Somalia, it's Somaliland. So most importantly, Somaliland healers offered their transmigrant patients who went back to Somaliland, an element of hope. So not only did people go back to get treatment by a traditional healer, but they also used other kinds of practices that span space in today's world. So that included phone calls, a lot of cell phone use in this part of the world, internet, and virtual healing rituals that are arranged by relatives and healers in Somaliland. So you have a virtual healing ritual where you don't actually have to be there, but the healer will say prayers and so forth for you. And then traditional medicines, increasingly, not just in Somaliland, but I've read another article about this happening in Senegal, move across national borders in the suitcases of friends and relatives who sometimes travel on behalf of a patient abroad and are asked to bring medication back to him or to her. And then finally, after treatment in Somaliland, some patients maintain contact with the healer, send them money and so forth, and then turn to him or her in case further problems arise. If you had success with your traditional healer, you don't want to break contact with that person. Then the kicker is this. When Maria did her study, she asked the transmigrants who were living in Europe, did you tell your doctor in Finland or UK, did you tell them that you're doing this kind of healing in Somaliland, either virtually or in person? And almost all of them said no. We don't tell them because we don't think that they would understand or accept Somali or Islamic concepts of illness and healing. So I was doing research in Finland for my New Century Scholar project, and I found similar evidence that by interviewing Finnish doctors, that they were unaware of the extent to which their Somali patients used traditional and transnational practices. Now, it is not, in that case, it's not yes or no, because many people use both, so they use traditional practices partly and Western medical practices as well. So I want to give you some numbers from that study. So here's the starting point. I asked the patients, do you value your ethnocultural belief and practices? And the answers were as follows. Most people, majority, valued biomedical approaches, but a majority partly valued their ethnocultural approaches. So it's a joint kind of approach. It's like the kind of thing that you want to diversify your investments, I guess you would say. You want to make sure if one thing doesn't work, the other might. So there's a lot of that going on. So then, how often do you combine biomedical and ethnocultural practices? And so these results show about 57% do this, at least some of the time. And then here's my conclusions, that the attending physicians didn't recognize or didn't correctly answer when I asked them about that specific patient. They did not correctly identify whether they did or did not or partially or never incorporated Somali healthcare practices in almost 90% of the cases. Now, nurses did much better. About half of the nurses correctly identified the extent to which their patients were either using one or the other or combined. So that's an interesting finding. So I think there's some broader implications here for global health that I wanted to discuss with you this evening. One is, I don't think it's just a problem in Finland. I think it would be probably the same thing here in Missoula, although I haven't done a study of this. And that is, I think most physicians in the North are not considering an individual's transnational space. And as a result, they're unaware of the personal healthcare inquiries and resilient practices that span borders. And as a result of this, they're unable to incorporate transnational approaches into a complementary or holistic physical well-being and mental health plan. And so northern providers fail in that regard. So in our recent article in Medical Anthropology, Maria and I contend that health specialists, both in the North and in countries like Somaliland, need to probe how today's patients, and here I would include the growing population of medical tourists, are practicing transnational health care. And then they need to incorporate those discoveries into a complementary health plan. So that should be, I don't know if physicians have this checklist of questions that they ask, but that should be one of the things that's on that checklist for sure. Not just of migrants, but of people who might be using health tourism as well. So now I'm transitioning a bit here. So if you're going to design a complementary healthcare plan, then you need to have interpersonal competence in contemporary transnational healthcare encounters. And this is my primary scholarly focus in the global health arena. And I refer to this as transnational competence, or TC. So I wanted to say a few words about what transnational competence is not first, and then I'll talk about what I think it is. So first of all, transnational competence is not taboo awareness. In other words, taboo avoidance. Learning not how to throw the peace sign the wrong way. That kind of taboo awareness might be pop cultural understanding, but it's a far cry from transnational competence, as I will be showing you in a minute. And transnational competence is not cultural competence either. So because of this reason, today's providers are encountering patients who are in transition from an unprecedented multitude of dissimilar nation states. So you can't just study one culture and decide how your patient might be treated. In fact, one of the problems with cultural competence is it tends to lump everyone from a particular country or ethnic group together, and what we call essentialize them, erroneously presuming that all group members follow the same practices. So Arthur Kleinman is a well-known anthropologist, medical anthropologist. 2006, he said the idea of cultural competence can lead to dangerous stereotypes, such as Chinese believe this, as if entire societies or ethnic groups could be described by these simple slogans. What's wrong with cultural competence? It misses the complexity and diversity of perspectives and behaviors that occur within ethnic groups due to a number of factors. One is mixed origins. Another is economic status. Another is religion, age, gender. All of these things make it much more complex than a simple cultural stereotype would suggest. So in addition to all of that, people have very unique transmigration experiences that shape their health needs and their health perspectives, as we've seen in terms of whether you've been in a transition zone or whether you've encountered discrimination in a reception place. This can have a major impact on it. And people also in transition are often going through an identity transformation. And so they often have multiple identities. It's not just one identity any longer, whether that be racial or religious or whatever it might be. So this is another reason. So the most promising healthcare approaches then focus on transnational as well as domestic influences, include socioeconomic status, include political analysis, along with individual cultural, subcultural, and blended cultural orientation. And then on top of all that, there's the unrecognized commonalities that people have, as well as their subtle differences. So the third thing that transnational competence is not is global competence. I think global competence is presumptuous because of this. I think few people, if any, interact on a worldwide scale. Most people are working in more than one place, and that's why they're have to be transnationally competent, but very few people are working everywhere in the world or expected to work everywhere in the world. So global competence is not necessary, nor is it really practicable, nor could you really develop global competence. So in sum then, we need a comprehensive framework that captures the multiplicity and variability of contemporary domestic foreign healthcare encounters without requiring global reach. And so I believe that transnational competence provides such a framework. Well, so what is transnational competence? And it's distinguished first by being multinational rather than culturally fixed, rather than requiring global reach. And it's multidimensional. It involves 5 core skills, and they're best learned through lifelong and life-wide learning. So I'm just going to select a few illustrations of each of these skills, and if you want, you can read some of my studies for more detail. I even have a book out called Transnational Competence. So analytic competence first. So here's some of the things that are important here. Understanding politically and socioeconomically unfamiliar health-related details, seeing the connectedness of issues, and being able to identify effective collaborative strategies. Next is emotional competence. One part of emotional competence is motivation, that you want to be motivated to explore what's unfamiliar to you. Interest and respect is important. Celebrating diversity is part of that. And then very important is empathy and emotional connectedness, kind of related to some of the things that Michelle Sayre was talking about last week, the sense that you can emotionally connect, recognizing that what somebody else is encountering is something that could very well affect you, and you want to be sure that you can help people as well, other people as well. And then there's the creative competence part, which basically involves things like synergy, lots of potential for bringing diverse perspectives together, including the synthesis of complementary biomedical and ethnocultural practices that I was talking about earlier. This comes under creative competence. And then communicative competence. Now, it would be great if you had verbal fluency in the language of the people you're treating, but because of the fact that so many people are moving into many different places, and because of the fact that your patients are going to be from many different places, it's unlikely you're going to have more than a smattering of words in any particular language. So that's why interpretation and using an interpreter becomes increasingly important. And that's a skill in and of itself. Careful listening, self-disclosure, and resolving communication misunderstanding. And then finally, there's functional competence, which includes, first of all, positive interpersonal relationships. It's very important. If you're going to move at all, you have to have establish a good personal relationship with the people that you're working with first. And treating counterparts as equals is a key part of that. I think Brian Sippy covered some of this in his talk. And then accomplishing tasks and achieving objectives. That kind of pulls it all together, that you're able to do what you set out to do. And then advocacy and referral are a very important part of functional competence. And TC professionals address the social and power context. They promote health rights of underserved populations, and they make specific policy recommendations and take specific behavioral actions. So all in all, across these 5 elements, the framework is concerned with 2 major objectives. One is improved health outcomes, and the second is reduced health inequities. So let's try to, for a moment, kind of place some of the lectures in this lecture series in the context of advocacy, downstream, midstream, and upstream. So first of all, downstream, I think that's pretty clear that the work of the Missoula Medical Aid is treating people in Honduras, giving people in Honduras different resources that they need. That I would call a downstream action. Midstream action. A couple of good examples of midstream action are nurses-led healthcare without harm, where they were able to reduce the number of waste incinerators, and then Partners in Health. I think Partners in Health is a very good example with their wraparound services, because they're providing not just medical attention, but food assistance, safe drinking water, transportation fees, job search assistance, building new homes, and so forth. They're trying to reduce the poverty traps that hinder recovery. And so in the midstream, capacity building is very important. So I just asked you to think about what lectures you've heard that fit into this category. And then finally, there is the upstream advocacy, and this really is the rarest. And so I have a quote here from Samantha Nutt, MD, in her book, Greed, Guns, and Armies in Aid. She says, it's easy to point fingers at the moral degenerates who opened fire on a busload of schoolgirls in Afghanistan in the name of some ill-founded religious or political agenda. It's more complex to follow the path of those weapons back to their point of origin and ask what might have been done to prevent such atrocities. That's what upstream advocacy does. And so maybe some of these lectures have done that. Very briefly, I think Paul Farmer exemplifies transnational competence, at least analytic, creative, and functional competence. And so the last part of my talk tonight has to do with how might transnational competence help with some of these health challenges that we have. And so I think the first thing is it's an advantage when you have unmatched transnational context. And so one of the things I did in my research for the New Century Scholar Program is I asked people to tell me whether or not TC, and I evaluated the TC of nurses and doctors, was associated with their ability to discern whether patients were using traditional medicine and with patient reactions to transnational care. So this is the research procedure I used. I used intersubjective interviews with all 3, the nurses, doctors, and patients, and here are the results. As you can see, very very few people were accurate on whether or not they use ethnocultural healthcare practices, but the most accurate were the doctors who were high on transnational competence. How about satisfaction? Again, 85% of the high TC doctors were evaluated as doing things that were satisfactory to their patients. So what do we need to do? First of all, we need to do educational transformation. We need to improve the medical school curriculum. Secondly, secondly, we need to do something about place. Well, some exciting things going on here. There's a global health core of professionals who are helping address gaps in place. Paul Farmer has called upon the U.S. to create a Marshall Plan that would expand and train people to do this. And there's an NGO called Global Health Core. There's several with the same name, but the one that is doing the best work is the one supported by Google.com and headed by Barbara Bush. And that pairs young professionals from the United States to work abroad in paid year-long assignments with organizations serving communities in East Africa, Southern Africa, and the United States. And they do that by working in a team of one U.S. fellow and one international fellow. 322 fellows since 2009, but I'm not sure if they're trained in transnational competence. And then very quickly, diaspora initiatives. It's great when, in terms of circular migration, if people who have left can go back, and either short-term or long-term. And the one good example is the Association of Haitian Physicians Abroad. The Haitian government has tracked some 1,400 Haitian diaspora professionals, mostly in the medical field, who have cycled through the country since the quake. And I think that's a really positive development. So access. TC's advocacy emphasis is in play here. You have to help mitigate access barriers by addressing the determinants of structural violence. And you do that through networking, coalitions, partnerships, and individual action. Let's go back to Syria for a minute. One of the things that's been done positively in Syria was, thanks to the initiative of Save the Children, there was a polio vaccination ceasefire, and they were able to vaccinate most of the children in Syria to prevent an outbreak of polio. So I want to conclude with my vision of the future. So I think there's two things that are, well, maybe I've got three things. Three things that are important in terms of my vision for the future. One is, I think it will soon be the case that all healthcare professionals will be virtually and physically mobile transmigrants, either physically mobile or treaty transmigrants. I think that's on our horizon. Secondly, I think that higher education institutions in the North and in the South, and probably in partnership with one another, will offer curricular and experiential learning opportunities that will build these skills in transnational competence. And thirdly, I think that TC-prepared professionals will be positioned to address transboundary health challenges tomorrow by advancing the continuing struggle, it's not an easy one, for place, access, and competence. So, thank you very much. So I know this is pretty heavy, but I think I can still handle a few questions if you want to, and if you have to leave, that's fine, because I've gone for hours.
Question over there, Peter.
Yes. You showed several examples of hospitals and education providers, and there seems to be a trend of going after health professionals to the extent of kind of decades. What is it? Because you used to be Red Cross society and private sector with producers. You were pretty exemplified, and now that's no longer the case, and it seems to be perfect. It makes it a little scarier going over if you want to work in another country. Or I never felt that way before, and now I do.
Well, it's absolutely true, and I think it's important that you go into things with your eyes open to But, you know, the issue is, what about security forces? And so some people will argue that people who are doing this kind of work, whether it be development work or health work, should be provided with some kind of a security force to protect them. And so there's some move in that direction, but there's a lot of resistance to that. On the grounds primarily that it's not quite the same thing anymore. If you're going in there as a really passionate humanitarian kind of person, or if you're going in there with this bodyguard and this military force surrounding you to keep you from getting attacked. So there's a lot of debate on that issue, you know, but I understand the problem. And how do we change it? I don't know.
I think it's going to escalate. They seem to get a lot of media attention when it happens.
Well, you know, my feeling on this is, if it's going to change, it's going to have to change from within. So what happens when Doctors Without Borders withdraws? And they're thinking about this right now in Southern Sudan. Well, then a lot of the local population don't get the services that they were getting before and that they really wanted. So, to me, they need to take action to make sure that those kinds of things don't happen again. They being the people of the country themselves. People are being denied. It's not something we can fix from the outside. It has to be fixed from inside. And they have to say, look, we want these treatments, and we're not going to put up with this, and we're going to provide our own protection. And you know, one of the things when I worked in Africa that it was a long time ago, of course, I didn't face some of these problems, but I always felt very comfortable working in Africa, and the reason was because I was surrounded by a really good group of friends, and I knew those friends were going to do everything they could to protect me. So I think that's why, you know, those personal relationships are so important. You know, it's not easy. It may take some time, it may take some bad events to occur, but I think that's what ultimately will be the answer. If people rise up and say, look, we're not going to have this anymore. These people are trying to do something to help us, and we want to make sure that they continue to do that.